Assalamu alaikum wa rahmatullahi wa barakatuh. Hello everyone. Welcome to another session for the free activity for part 2. We are going to discuss today some maternal infection questions. Hopefully, we are going to cover as much as we can in 1 hour. So I'm not going to be a burden as every time. Okay, I'm going to be quick, so try to help me out. We want to cover the tricky questions and the basic questions. Okay, so the first one we have now is a very basic question, but it depends on the diagnosis. So if you can help me out, please, can you tell me question one, what would be your diagnosis? This woman that came for antenatal care at 20 weeks complaining of watery pervaginal discharge, rash on palms and soles, and her baby showed ascites at anomaly scan. Without the diagnosis, you are not going to know the answer. I got an answer, but I didn't get the diagnosis yet. Do you have anything in mind? What can lead to rash on palms and soles, and the baby is having ascites, plus the woman is having watery discharge? Yes, this is syphilis, but what kind of syphilis? Because I have seen correct answers also. This is primary syphilis, or secondary syphilis, or latent syphilis? Excellent, excellent. This is secondary syphilis, and by the way, it's very famous in the exam. To have a question for diagnosis, not management. The management is really easy. We all know that the syphilis management is antibiotics, bendazine, penicillin, or penicillin G. Okay, can anyone tell me if this patient is having any kind of sensitivity to penicillin? What would be the appropriate agent for her treatment? It's not, if it's not within the options for you, you can tell me out. What would be the appropriate agent for her management if she is having sensitivity to penicillin? Okay, you know that before, once upon a time, it was erythromycin. But take care, please, that this is in the past. Now, when we have sensitivity to penicillin, we are going to offer her ceftriaxone. Yes, not anything from the macrolides. Syphilis now is resistant to macrolides. So take care if the question is old, okay, or the answer is old in some books. Excellent, everyone, mashallah. Okay, the next one is also very basic one. The woman is having slap cheek syndrome, or she's exposed to a case of slapstick syndrome. She has never had this uh, syndrome before. She is saying that she is concerned about her pregnancy. The blood test is negative for IgG, positive for maternal IgM. Before going through the choices, I need someone to tell me what is her immunity state right now. Can you say that this woman is immune? This woman is having active infection or primary infection, chronic infection, or what? Yes, excellent. positive IgM with negative IgG, this is recent or acute infection. And of course, she's not immune. Right. In case she's having IgG positive and IgM positive, can you say that this woman is having immunity or she's having a recent infection? What should be your next step if both of them are positive? Excellent, Dr. Laila. Avidity test. Look, guys, parvovirus, CMV, rubella, those are viruses that have characteristic thing in serology. If both of IgM and IgG came out to be positive, we still don't know if this is a recent infection or chronic infection. We need to do what's called avidity test, IgG avidity test. This is going to tell us if this patient is having a recent infection or this is a chronic infection. Why? Because in those viruses, IgM can persist positive in the blood for a year. So this could be a chronic infection. And you know that chronic infections are not having so bad diagnosis during pregnancy. What we fear for is the primary infection or recent infection. If we have a low avidity, that means that this patient is having a recent infection. If I'm having a high avidity index, which means that the IgG is high, that means that this is a chronic infection and probably the prognosis is not going to be very bad. Sometimes it's going to go through very nicely through pregnancy without any complication. Here in this question, we are having a recent infection. What would be your answer? Do you remember the algorithm for parvovirus? Are you going to discharge her? Are you going to reassure her? Of course not. Of course not. We need to do something for this baby. We have to keep our eye on this baby. Parvovirus is going to be manifested to the woman by a flu-like symptoms, just like having a common cold, just like having a flu. But to know if this baby is having a congenital infection or not, we are going to depend on two things. We are going to depend on the ultrasound biomarkers. And if she want to make sure that her baby is really infected or not, what you are going to do? Let me put it in a question. If you want to confirm congenital parvovirus infection, what investigation or modality you are going to use? No, not ultrasound. Ultrasound is not specific for parvovirus or CMV or rubella or any viral infection. If you want to make sure a definitive diagnosis for congenital infection, yes, excellent. Invasive diagnosis. Whether it was amniocentesis, chordocentesis, CMV, according to the gestational age. According to the gestational age, you are going to take sample from the amniotic fluid, from the villi of the placenta, or chordocentesis, which is not really used for viral infection, but we can do it also. Okay, got it, guys? So this is the definitive diagnosis, not the serology, not the ultrasound biomarkers. We use the ultrasound to detect if there is any congenital abnormality is there. And for parvovirus, we are looking for a specific thing. If this specific thing came up, we are going to interfere. But if other congenital anomalies are there, we are not going to do anything. We are just going to wait for the baby to be delivered, or we can option for termination. But there is very specific complication. If it happens, we are going to interfere. And it's very specific to parvovirus. What it is? Excellent. Fetal anemia. Fetal anemia, which is going to be manifested by hydrops. Yes, you are all right. We are going to have hydrops, and hydrops mean that we are going to search for fetal anemia. Okay, what would be the Doppler of choice for detecting fetal anemia? Excellent. Middle cerebral artery Doppler. Excellent, guys. So that's it. That's it. We are going to offer her follow-up, of course. Yes. What else? We need to follow up this baby. And you are going to do this not just recently after detecting the IgM in her blood. It takes time. It takes like 2 weeks. In CMV, it can take more. So we are going to wait for some time, and then we are going to do the ultrasound to see if this baby is really infected or not. So the right answer here would be D, fortnightly ultrasound until 30 weeks. And accordingly, we are going to make our mind about the next step. Excellent, mashallah. We are covering the basics here. Okay, the next question. A community midwife asks for advice regarding a 20 weeks pregnant woman whose son has developed chickenpox a day before. The woman is not sure if she has had chickenpox herself. So I'm having a woman with no symptoms. She is exposed to chickenpox and she want to know what to do. Immediate management. See here in the SBA, they play on words, or they play with words. This woman who is asymptomatic, can I give her immunoglobulins or not? Yes or no? Yes, of course, I can give her immunoglobulins. However, they are saying what will be the most appropriate immediate management. And this is not the immediate management. I want to make sure about the immunity of this woman first. Right? Yes, because maybe she's going to be immune. So no immunoglobulins are required. Nothing is, we are not going to fear about anything. So the immediate management is to check the immunity for any woman who is asymptomatic and exposed to chickenpox. Right? The next step would be giving her immunoglobulins. Okay, another question. What we fear about more? Having chickenpox before 20 weeks or having chickenpox after 20 weeks? Which one is more severe? Yes, exactly. After 20 weeks, and specifically speaking, after 28 weeks. More specifically speaking, around delivery. Uh, 2 weeks or 1 week, very, very specifically, the most severe period is having chickenpox 1 week before delivery or after delivery. So 1 week around delivery. In the first 28 weeks of pregnancy, the risk for neonatal infection is low. The risk for having complications is low. So we're good. So far, we're good. Excellent. Those I'm still talking about the basics. I wanna be cute. I don't wanna go deep. So let's have another question through the basics. We have here a herpes zoster case. This case is primary, and she's calling the maternity assessment department for advice. Her husband has been diagnosed with herpes zoster, and she thinks she has not had chickenpox in the past. She is 38-week pregnant. Is there? Yes, well, we're still the same. Still the same. Yeah, nothing is going to change. We need to check the immunity. We need to check the immunity. The pictures here are not really great. So anyway, let's be here. Yes, nothing is going to change. But something is really important here, guys. If this woman came out to be non-immune, can I give her the IG or not? Of course, we can give her if she is asymptomatic. If the woman developed the rash, can we give her the Varicella zoster IG or not? No. Rash equal no IG. Rash means we got the virus, so we need to treat it. We are going to give her now a cyclovir treatment. Excellent. Okay, so no rash, we can give the immunoglobulin. Rash, no immunoglobulin. The best timing, as you all saying, for starting the treatment is within 24 hours from the start of the rash. In this case, when the patient is 38 weeks, she's about to labor any minute now. Give her, please, the acyclovir, because this is what you can do. And of course, we are going to assess the baby for any symptoms of varicella zoster. Take care of the fetal monitoring after labor. Okay, we have here a case for malaria. I'm not going to say no acyclovir if the rash started more than 24 hours ago. We are going to consider acyclovir, but it's not contraindicated. And consider means that you should tell your patient that the efficacy of acyclovir now is not really good. Okay, but it's not contraindicated. Take care. So even in the exam, when they bring you a case with rash, and it was 2 days before, 3 days before, and there is nothing that can make sense within the choices but acyclovir, go for acyclovir. And of course, according to the severity of the symptoms, you are going to give her oral or IV acyclovir. Here we have a case of malaria. And the thing about malaria is that many doctors don't know the difference between mild malaria and severe malaria. Here we have a patient with fever and flu-like symptoms, no GIT symptoms, recent travel to sub-Saharan Africa, and the investigation confirmed less than 2% of RBCs parasitized by Plasmodium falciparum. Please tell me, from this scenario, is this mild malaria or severe malaria? Forget about they already have told you. I want you to tell me from her symptoms, this is mild. Okay. How you make your mind about being mild malaria? Okay, you all are talking about investigations, which is less than 2% parasitemia. Yes, this is true, but also from the symptoms. You know what severe malaria? Severe malaria is organ infection. Organ infection. The patient is unstable. The patient is confused. I'm not talking about fever, chills, flu-like symptoms, even if she's having nausea and vomiting. This is not severe malaria. Severe malaria means she's having neurological symptoms, convulsions, loss of conscious, coma, liver affection, renal affection. Yes, hypoglycemia, excellent. Okay, this is severe malaria. Plus, we are going to find in the investigation that the colonizations of the RBC is more than 2%. Okay, if you are having a case of mild malaria, are you going to admit her or let her have her treatment at home? Uh, I'm really happy that some of you got it wrong. I'm really happy because you are not going to forget it ever. Any case of malaria should be admitted. You should not give her the medication and let her go home. Even mild, yes. Why so? Because treatment is really ugly and the side effects of the treatment is really ugly and none of the patients are going to be compliant to the treatment if you took it at home. And anytime the parasitemia can be more than 2% and this woman can go into coma like this. So even uncomplicated malaria need admission. But admission in hospitalization, I'm not talking about admission to the ICU. Severe cases is going to be admitted to the ICU. Okay, guys? So please take care of this when you are answering EMQ because they are going to say at home medication, community treatment, admit her to the ICU, admit her to the labor ward, admit her or hospitalization. We are going to admit her, okay, but not to the ICU. To make sure that she's going to comply to treatment. Parasitemia more than 2% is severe malaria. But usually she's going to have symptoms. Very rare to have mild symptoms with more than 2% parasitemia. Malaria is wild, by the way, very wild. Okay, so what would be the treatment here? It's going to be according to the type of malaria. if we are dealing with falciparum or mixed malaria, then the optimum regimen is quinine plus clindamycin. If we are dealing with Vivax or Oval alone, then the best would be chloroquine. Excellent. Someone remind me, please, what would be the best agent and the one that is used in the UK for prophylaxis? If this woman has just come from sub-Saharan Africa or she's going to travel to sub-Saharan Africa, there is no symptoms, nothing. Mefloquine, yes. Mefloquine is the first one to be chosen because most of the regions now are chloroquine resistant. So mefloquine is the best agent now. Unless they told you, and it's never going to happen, that the area that the patient is going to is chloroquine resistant because they are giving you the answer. So mefloquine is the best agent. Excellent. So you all agree now that oral quinine and clindamycin here is the best choice. Not intravenous quinine, of course. Excellent, guys, mashallah. Okay. Okay, here. This patient with pelvic girdle pain who has been booked for induction at 39 weeks. She's diagnosed with primary varicella zoster at 38 plus 6 weeks. What would you recommend to reduce the risk of neonatal varicella infection? Take your time. She is booked for induction at 39 weeks, and unfortunately, she got the varicella zoster just 4 days before induction. Okay, so some of your colleagues are saying deliver her by elective cesarean section. This is, by the way, one of the options that you are going to give the patient. Only if there is no rash on her tummy. So, you know, this is not the best choice. Even if she's going to have any kind of epidural anesthesia or spinal anesthesia, you are going to choose a place that's free from vesicles to insert the needle. If we are in part 3 now, yes, exactly, until it has crossed it over. And she just started the rash 4 days ago. Okay, so anyway, this patient, if you are in part 3, yes, you are going to counsel her about her options. But the safest choice now that would really reduce the risk of neonatal varicella infection is to delay the induction for a week. If by any means, she got spontaneous labor, what you are going to do? What would be your best next action? While waiting through this week, the woman went into spontaneous labor. Yes, yes. Cover her up. Cover her up with acyclovir because nothing else to do. I'm going to give her IV acyclovir during labor, and I'm going to give the baby also acyclovir after delivery. And of course, we are going to run some tests for this baby, and according to the symptoms, whether we are going to take a swab from the CSF or not, according to his symptoms. Both of them, Dr. Az is going to need a cyclovir. Anyway, this patient now, when she's having primary varicella zoster, she's going to take a cyclovir anyway. Okay, but according to this scenario, the best next action is delaying. If she went into spontaneous labor, then the best next action or the immediate action would be IV acyclovir, of course. I'm just trying to open up scenarios with you according to how the question can come. And by the way, until now, this question is a recall. And it can come like this, and it can come in percentage, and it can come in decimals. The estimated risk of early onset GBS in UK. It can come as a percentage. It can come like this, and it can come in decimals. So remember, this is one of the most appearing recall. One in 200, which is 0.5. Yes, excellent. Previous question. Previous question here, delay induction for a week. This is the only thing that can reduce the risk for neonatal varicella now. You know why we delay the induction for a week? We are giving time for the antibodies that the mother is going to develop to reach the baby. What's called seroconversion. The mother now is infected. Her body is going to produce antibodies. Those antibodies can reach the baby. So I'm just giving her time for those antibodies to reach the baby. And this is why when you have recurrent varicella zoster, we don't really fear of anything because this woman is having already antibodies, and these antibodies are going to transfer to her baby. So she can have a vaginal delivery. She can have treatment if she's having severe symptoms. But you know, in recurrent infection, if the patient is having mild symptoms, no treatment is needed. This is the difference between primary and recurrent. And this is why also, when the patient is having primary infection in the first and second trimester, she can have a vaginal delivery. Very safely. But it's not a must. It's not a must for a patient who is having a third trimester varicella to have a cesarean section. It's not a must. It's a matter of counseling. Pros versus cons. Okay? If you wish to deliver by elective cesarean section, okay. Okay. No one is going to blame her. But when they say that she has been booked for induction at 39 weeks, that means that this lady has option for vaginal delivery already. You got the trick? Also, having a pelvic girdle pain is not an indication for cesarean section, by the way. You know this? And I think this is a recall also. Pelvic girdle pain is not an indication for cesarean section. The patient can have a vaginal delivery with epidural, with painkillers. We need to counsel her about having normal vaginal delivery. It's going to be safe. It's not going to affect her condition. Her condition is not going to be improved by having a cesarean section. Okay. So here I was telling you, take care of this question because it can come like this. It can come as 0.5 to 0.6. It's exactly 0.57. Okay, it can come like 20%, if I'm not wrong. Yes, exactly, Dr. Farah. If she came in a spontaneous labor, of course, we are going to give her the IV acyclovir for her and the baby, and we are going to observe the baby for sure. Anyway, the baby is going to have swabs from everywhere except for the CSF, unless he is having neurological symptoms. Okay, some GPS questions. And I know that GPS is a problem for many reasons, and I don't know why actually. Those are easy marks. Maternal infection are easy marks. Early pregnancy problems are easy marks. Save the marks that you are going to lose to labor module. Okay, so I want you to go to the exam and answer those questions all correct. Here we are having a woman, 38 weeks, history of rupture of membranes 6 hours ago, apyrexial, not having contractions, draining glycosh, and you discover that she has been recently treated for GBS UTI. So, in short, if I was in the exam, I would write down from plus GPS, and the patient is not septic. From plus GPS equal excellent. Immediate induction. We have two indications for immediate induction in our college. Having GPS with prom or pre-prom, and the patient is going to have a vaginal labor. Having HIV with prom or pre-prom, and the patient is a candidate for vaginal delivery, which is what her viral load is what to allow her having vaginal delivery. Excellent, less than 50 copies. So HIV viral load less than 50 copies, good CD4 count. This patient is going to need immediate induction if she's having prom or pre-prom. You can say now that she's having a green light for the virus to pass to the baby. The membranes are breached. So when you don't have intact membrane, this is the green light for GPS or HIV to reach the baby. Immediate induction. So here we are going to do augmentation of the labor. She is not having any contractions, okay? And prophylactic intravenous antibiotic immediately or when she is contracting. Are you going to choose B or C? When do we start the IAP? As soon as possible. As soon as possible. You are not going to wait for the contractions to start. As soon as possible, guys. Once any signs of labor come out, whether it was the rupture of membranes, the contraction starts, any sign of imminent labor, start the IEP. So here we already have rupture of membranes. Okay, Dr. Rinko, take care that maybe a patient with normal delivery, okay? This woman is at term. This woman is at term. And she is contracting with or without rupture of membrane. Okay? And you know that she is GBS positive. Start the IEP. If the woman is having rupture of membrane, but without contraction, start the IEP. Okay. The next one. This woman with GPS carriage in her current pregnancy. She's having history of rupture of membranes at 33. P prom. Yeah, the previous one is B. Immediately. The augmentation and the antibiotics immediately. This woman who is having a P prom, she's well and is not in established labor. I don't need to continue the scenario, honestly. I don't need to know that her previous baby was admitted to the neonatal unit. If I go get through here until here, and this woman is having a P prom, she's having a P prom with previous GPS history. I don't think I need to know the status of her baby. But it would differ. It would differ if she is not having rupture of membranes and she is carrying GPS in the post-pregnancy. In this case, I need to know the status of the baby to give her options. But let's see this patient first. Okay, she is 33 weeks. And our guideline is very clear about this. When a patient is having a PPROM and she is not having established labor, are you going to deliver her or you are going to give her something? Are you going to do immediate induction? Let's take it step by step. She is not in established labor and she is PPROM and she have a previous history of GPS. If this woman was at term, I would induce her right now. But this patient is premature labor. Okay, they give you another piece of information, which is her baby was admitted with GBS infection, to tell you that this patient needs IOL. They are tempting you. They are tempting you to induce her. Take care, guys. Prematurity here wins. So you are not going to induce this patient. We can watch and see. We can watch and see. I'm not going to induce her. Okay, now the next step. What I'm going to give her. Can I give her steroids? Okay, you can. You can give her steroids. Okay. As any PPROM, are you going to give her erythromycin or not? Yes. You are going to deal with her like any PPROM. Okay, but we are not going to induce her. Because here, when we weigh the prematurity versus the GBS infection, prematurity wins. This is according to our guideline. This is not my opinion. So we are going to give her steroids, give her erythromycin, observe her. By any means, if she went into established labor, she's going to have immediate augmentation and IUL, IAL, okay? Yeah, so what? Now she's having a preterm labor. What you wanna do? What you wanna do? Are you going to induce her? You want to induce her? Your guideline is saying no, don't do this. If she is not in established labor, don't induce her. Give her time. Give her time. Because the baby is going to die from prematurity more than the GBS. Yes, exactly, Dr. Rinku. Benzostine penicillin or benzyl penicillin is given in intrapartum. It's called IAP, intrapartum antibiotic prophylaxis. In this case, she is PPROM. She's going to be treated like any other PPROM. Excellent. Thank you for bringing us the recommendation from the guideline. IAP is recommended for women in confirmed preterm labor. This woman is not in established labor yet. And this is the trick about this question. So here you are going to favor waiting more than treating the GBS. Because the studies has shown that being born prematurely going to affect the baby morbidity and mortality more than the GBS. You got it, guys? This is really a good question. So don't rush for admission and induction unless they have told you in the scenario that the patient is having regular contractions. This is established labor. Or she's having cervical dilatation 4 or more. This patient is already in the first stage. Less than 4 centimeters. No regular contractions. This patient is not in established labor. I can wait. If I can wait for another week, it would be an advantage to the baby. And anyway, if we are talking PPROM wise, most of the ladies who are having a PPROM are going to deliver maximally in 1 or 2 weeks. Patients who are having PROM at term are going to deliver within 72 hours. So we are just buying time. That's it. Even for the steroids to work out. If the patient enter active labor according to her obstetric condition, it's not about the GPS. According to her obstetric condition, if she is willing to have a normal delivery, goes through normal delivery with IV benzyl penicillin. If she is having any obstetric reason for having CS, go for CS again with IAP because the membranes are ruptured. If the membranes are intact, she does not need IAP. Okay, guys? Let's see another one. Okay, here we are. This woman with 36 weeks of gestation with a history of a previous cesarean section. Okay, he is telling us that you can go for another CS. Okay. Her previous baby was affected by GPS. She is keen to deliver vaginally. Okay, why not? She has been assessed by a consultant and she is suitable for a vaginal delivery. Her vaginal swab at 36 weeks is negative for GPS. I have a question for you. Do we do screening for GPS? In UK, do we do screening? So why this patient had a vaginal swab at 36 weeks? If you know this, you are going to be brilliant. Why this patient? Excellent. This patient is having a swab at 36 weeks because she had a previous baby with infection. So here we are. We are going to give her two options. She's going to option for IAP blindly, or she can have a swab near term to detect her status of GPS. And accordingly, she can have IEP or not having IEP. This is the only indication for having screening during pregnancy in UK. Yes, excellent. We are doing the swabs 2 to 3 weeks before labor. So it's like near term. And for the twins, excellent, Dr. Osei. I'm so proud of you. We are going to do it much earlier. Yeah, sorry, 3 to 5 weeks. Thank you. 3 to 5 weeks prior to delivery. Okay, so what you are going to do here? The patient came out to be negative. The consultant said that she is okay for a trial of vaginal delivery. Okay, I'm getting many C's. I'm getting many C's. So you all agree that this patient needs IAP. Even if her vaginal swab is negative? So you are solid about, mashallah. You are all solid about it, and you are right. You are right. Take care of the basket. You are right, guys. MashaAllah. So they tricked you with having a negative vaginal swab. Of course, as Dr. Rinko is saying, there is a possibility of false negative screening. And having a previous baby who has been affected by GPS is one of the indications that this woman, the best or the ideal management for her would be giving her IEP in active labor. Answer of last question. Uh, you mean this one? Immediate. Immediate. No. This one. Administer steroids, oral erythromycin, and observe. Okay, we are not going to induce her because the baby is premature and she is not in established labor. Okay, girls, wallah, I'm so proud of you. Okay, I need another question for GPS. It's not here, we can have this one. Let's have another one. Okay, here we are. A 35-year-old woman attended for induction of labor at 35 weeks. She presented with preterm pre-labor rupture of membranes at 28. Wow, she managed to stay in one piece until 35 weeks. A course of oral erythromycin and IM steroids has been completed. All maternal and fetal observations are normal. She has no known allergies. What you are going to do? In my humble opinion, you should have answer before going through the options. This is the ideal technique for EMQ. You have an idea about the answer, and then you are searching for your answer within the options, and then you are going to choose between 2 or 3 choices to get the best one of them. Okay, for sure, this woman is going to need IAP. Excellent thinking, Dr. Laila. She does not need broad spectrum antibiotics. She's not in sepsis. Okay. She has no allergies, so it's going to be benzyl penicillin. Now the question is, would it be in active first stage or before induction of labor or once labor starts? Yeah, in the guideline, nothing tells us to start the antibiotic before labor. Okay, we have discussed this. Once the patient is having ruptured membranes or contractions or cervical dilatation or both of them or all of them, we need to start the IAP. So once labor starts, just like our guideline is saying. Okay, another one. I think it's talking about the follow-up of the neonate, right? So do you remember how often we are going to monitor the baby for signs and symptoms of GBS? If this baby's mother is not having any previous history of GBS and she took the IEP, would it be different from another baby whose mother didn't have the IEP? Of course. But this woman took the prophylactic doses during labor. So this baby need 1 and 2 hours, then every 2 hours for 12 hours, which is 0, 1, 2, then every 2 hours. Again, again. We are having two scenarios. We are having a woman who took the 3 doses of prophylactic antibiotics during labor. And we have a case who didn't take IEP during labor. And we have a case who took the IEP, but she had a previous history of GBS. Okay, guys, I told you, EMQ needs an answer before going through choices. When you see numbers like this in the exam with the stress and everything, you are going to get somehow temporary blind by numbers. So you need to write down the answer and search for it within the options. At least this is what I do. If we choose A, neonatal vital signs every 2 hours, this is not, I'm not saying not incorrect, but it's also not correct. It's mentioned like this: 0, 1, 2, then every 2 hours for 12 hours. So now he's going to be examined just after labor, then after 1 hour, then after another 1 hour, then every 2 hours for 12 hours. If the baby is clinically well and the mother received IEP for prevention for more than 4 hours before delivery, he is not going to require special observation. Special observation means more frequent observation. Okay. Let me remind you of the signs and symptoms of GBS, because maybe in the exam they are going to ask you not directly They can give you a case who is not having signs and symptoms, and another case who is having abnormal behavior, which is abnormal cry, floppy, difficulty with feeding, abnormal temperature, rapid breathing. He's usually going to have low upgar score also. Any change in skin color, any kind of rash. And the numbers are really important. If you want to take a screenshot of this screen, please do. Okay, the numbers are really, really important. A mother with a previous carriage state, the risk of the baby is going to be 1 in 700 or 1 in 800. If she's having a current positive test, the risk is 1 in 400. If the mother is negative, the risk would be 1 in 5,000. I'm really sorry, but I'm not the owner of those files, so I cannot send it to you. Those mocks are part of our revision, but those are old mocks. We usually do another new one with every patch. So those mocks are like this one, for example, I made it for January patch. This one for the previous patch, previous year. So I think it was 2022 to 2023. This one is a very recent one. I just did it last month. And I'm going to do another one with revision course, inshallah. Everything needs to be updated. Okay, I need another GPS. You know that GPS is one of the ugliest questions ever. GPS, GPS. Okay, have you covered the TB? TB is a recent talk article and it can come in the exam, by the way. Let's test our knowledge. This woman here is admitted in spontaneous labor with concealed pregnancy. 3 days following delivery of a term infant, she is diagnosed with pulmonary tuberculosis. So the woman just had delivery, and we discovered that she is having pulmonary TB. What you are going to do? Can the mother, by the way, can the mother breastfeed? I'm getting some eyes. Okay, she can breastfeed, but she have to take care of not contacting the baby by breath or by mouth secretion. I think they mean that she kept her pregnancy hidden. She is admitted in spontaneous labor, so she does not have any antenatal care. Okay, I'm having different answers. So let's see what's the answer. This means, guys, that she is having latent tuberculosis because she is asymptomatic. Why? Because we discovered incidentally. When she went in labor, nothing was obvious on her, okay? So in this case, the treatment would be isoniazid for 6 months plus pyridoxine. We give the pyridoxine for neurological protection. Any woman who is going to take isoniazid is going to take pyridoxine. Okay, so we have two regimens. Either you are going to give her the isoniazid alone for 6 months, or you're going to give her a combination between isoniazid and rifampicin for 3 months. That's it? No. We need to do a tuberculin test at 6 weeks to make sure of her status now. Okay, I know TB is really ugly. The neonate usually is not going to need anything, but we can test him. And he can take the vaccine, of course. He can take the PCG vaccine. TB is a disease that usually is going to affect the mother more than the baby. This is why we focus more on the mother. Okay, this one is good. I didn't mean to bring it, but what do you think? If you are having a woman who tested positive for syphilis, what test should be used to confirm diagnosis? We need something specific. We need a treponemal test. What would that be? Okay, so you all say C, and you are right. Fluorescent treponemal antibody absorption test. This is the confirmatory test. Okay. And usually, guys, by the way, when we do something for screening, whatever you have chosen for screening, you are going to choose another one for confirmation, not the same one. Okay? None of them are above the other, the treponemal tests, I mean, because all of them have a false positive and false negative results. But at least, if you are going to do something for confirmation, go for the antibody test, the treponemal antibody test. Okay, I'm searching for GPS, honestly. I don't remember which one. I don't remember the choice. And I don't want to go in HIV because HIV is going to make you cry. Frankly speaking. Okay, this one is good. I chose this question for two reasons. Number one, this patient had a GPS UTI at 20 weeks of gestation. Are we going to treat her if we are now at 20 weeks? Are we going to treat her and offer her IEP? Are we going to treat her only? Are we going to give her IEP only? I'm getting conflicted answers. Okay, forget about my question. Let's make our mind. Is this a mild allergy or a severe allergy? See, it's a very humble question. but it depends on how much we know about the signs and symptoms of allergy. Okay, rash and vomiting are not severe allergies. Severe allergies, guys, is when you are having organ involvement, mucosal involvement. So the patient is having respiratory edema, tongue edema, oral edema, uh, eyelid edema. She's swelling up. Okay, in simple words, she's going to blow up. Okay, desquamation of the skin, not rash like this. Desquamation of the skin, blistering of the skin. But the benign T cell mediated reactions, which is some rashes, maybe vomiting, are considered to be mild allergy. Okay, sometimes when we have pruritus or something like macules, raised rash, raised rash, not a flat rash, you are going to worry a little bit. But also it's considered mild, not severe. So now you know you knew the signs and symptoms of severe allergy. Okay, when it involves the mucosa, when there is skin desquamation, okay, when it can involve organs also, or there is a loss of consciousness, or there is difficulty of breathing, of course. So here, this is mild allergy. Mild allergy means I'm not going to give her the benzyl penicillin, but I'm going for cefuroxime. Okay, and why the IV cefuroxime? Because she is in spontaneous labor now, 39 weeks. So it's a very simple question, but we can lose it for a very stupid reason. Okay, I'm not going for HIV now because I know you are still shocked with the GPS. Mm. Can you guess the code for this? Yeah, likely it would be herpes simplex, right? Very easy one. Okay, would you tell me, please, what would be the most pathognomonic symptom or sign that would make you think about COVID-19? Change something in this, in her vital signs. If you would change something in her vital signs that could lead you to COVID-19, what would it be? No, not the pulse. Excellent. Low oxygen saturation. And severe cases are going to have oxygen saturation less than 96 or 94. Usually we are going for 96 oxygen saturation. So take care of this. Okay. This is basal. I don't want basal. I think I'm having one in the very beginning. Okay, here we are. This woman with ruptured membranes, 27 weeks. The woman was found to have GPS, bacteriuria. Okay. All maternal observations are normal. There is no uterine contractions. Cervix is still long, closed, clear liquor. Baby is not having tachycardia. If spontaneous labor does not ensure, delivery should be offered after. After doing what? Or after how many weeks? Okay, I'm having different answers. Okay, if I'm having this question with multiple options, I would give this woman the erythromycin. Okay, I would give her corticosteroids, and I would wait. But here, they are not asking about this. They are asking what would be the timing that you should offer delivery. If she's still calm, if spontaneous labor does not start. So here they are looking for a specific something. And it's not about timing, guys. Okay, it's not about timing. We need to give her treatment of PPROM. This is what's important. I don't want this patient to have infection or the baby have infection. So the most important thing is to give her a 10-day course of erythromycin. If we can give her a 10-day course of erythromycin, this would be great. But we are going to start the erythromycin, and then she can have delivery anytime. This is for her own protection. So nothing in the guideline is telling us to induce labor by specific weeks. If you have something like this, you can show it to me. I have read the guideline like a million times, but maybe you have something that I don't know. There is nothing in the guideline that tell us to induce the labor by a specific week. Here we are dealing with a case of PPROM. So think about the PPROM guideline, the NICE guideline. Okay? And yeah, I know that you all are, she's not going to do it all this long, but guess what? Sometimes she can do it until 35 or 36 weeks. What's important is when the patient is not in established labor. I'm worried about infection. If the patient in established labor, I'm going to worry about other things. I'm going to worry about neuroprotection of the baby, for example. So I'm going to give her the magnesium sulfate. If the patient is about to be in labor, like for example, she is having intermittent contractions, but the cervix is dilated, starting to dilate, okay? So, okay, I'm going to give her the corticosteroids. If the patient is having regular contractions, but the cervix is not yet dilated, I'm going to give her tocolytics. P-prom management is going to be according to the case. And you should be aware of what you want, what you are aiming for. By the way, corticosteroids are correct, is correct answer. Erythromycin is correct answer. If she was having contractions, tocolytics is correct answer, but it's about priority because this is a theoretical exam. What would be your priority now? My priority that I'm not going to offer delivery until she completes her course of erythromycin. This is my priority. If corticosteroids was there also, okay, magnesium sulfate, magnesium sulfate, Dr. Iram, is given or offered for patients who are having imminent delivery within 24 hours. If this patient is having delivery within 24 hours, give her magnesium sulfate for the fetal neuroprotection. Yes, established labor and dilated cervix. Not any kind of established labor. It's not like having only contractions. Contractions with dilated cervix. Okay, Dr. Khan, I think you have joined recently. This case is not like any other case of GBS. This case is a P-prom. So prematurity here way the GBS infection. Prematurity could kill the baby. GBS not. So according to our guideline, if you are having a case of P-prom, the patient is not in established labor, treat her like any other case of P-prom. Even if she's having positive GBS, yes, even if she's having positive GBS. Am I going to give her erythromycin now? Yes, you are going to give her erythromycin now. And when she go for established labor, you are going to give her the IAP once the labor starts. So here, the correct answer is give her 10-day course of erythromycin, like any other P-prom lady. See here, I got you this from the guideline, by the way. A pre-labor positive GBS culture does not change management in pregnancy with gestation of less than 34 because of high morbidity associated with early preterm birth. This is why we are not going to initiate the labor. We are not going to induce the labor. We are not going to augment the labor. IEP is going to be given once labor starts. It's better not to go beyond 34 weeks. It's better not to do this. It's better to induce the labor by 34 weeks. But this is not offering, this is not a routine. Yes, early intervention may be preferable. But if the woman is stable, she is not having any kind of pyrexia, she is okay. We had the swab and the decolonization. I can wait. So this is not our issue here because it's going to be case by case. My immediate management, my aim My aim now for any case of PPROM, number one, protect her and the baby from vaginal infection, erythromycin. Give her tocolytics if she is having regular contractions. Give her magnesium sulfate if labor is really imminent, which means that she's having regular contractions and cervical dilatation. Definitely, if she went in labor, I'm going to give her IEP. Are we all on the same page here? It's tricky because it's talking about PPROM, and usually when you see a GPS with PPROM, you forgot everything about PPROM and focus only on GPS. But it's not tricky. Here, for example, we are having a lady, she is at 20 weeks, she's found to have GPS bacteriuria. What are you going to do? Are you going to treat the GPS, or you are going to treat and give IEP, or you are going to give IEP only? I'm going to tell you something. If they didn't mention the culture count, treat and give IEP. Okay? If they didn't mention the count. But if they mention the count and they told you that the colonization is less than 100,000, what are you going to do? Treatment, not IEP. Treatment now is not warranted if the colonization is less than 100,000, but she should have IEP. You know what GPS bacteriuria means? The woman is having bacteriuria. When we do the culture, it came out to be GPS. Okay? So, because we know that GPS can reach the baby and do what's called by neonatal GPS disease, okay? So, this is why we offer IAP. But like any other bacteria, when the colonization is low, when it's less than 100,000, it does not warrant antibiotics. Because usually you have already started broad spectrum antibiotic before the culture. Yes, if it's less than 100,000, IEP only. No treatment, no current treatment for the bacteriuria. If they didn't mention anything in the question about the culture colony, then you are not going to assume that it's slow. Okay, positive GPS is positive GPS. I'm going to treat it and give IEP. You got the difference? In any way, the woman is going to have IEP. But treating the bacteriuria depends on the colony number. If it's more than 100,000, then she needs treatment. antenatal antibiotics. If it's less than this, she does not need antenatal antibiotics. If it's not given, then you are going to assume that this is positive GPS with gross greater than 100,000. I want to say something, but I don't want to conflict you. If the gross is less than 100,000, this is negative. This is negative culture anyway. But because this is a theoretical exam, and I know that there is a question in Dr. Andrew Caesar's book about the number of the colony, so I'm just trying to make it clear for you. In real life, it's not like this. So what? So what? This is why we do asymptomatic bacteriuria. We treat asymptomatic bacteriuria. In UK, we do screening, urine screening at each visit, at each antenatal care visit by the urine strip. If the urine strip shows positive for pus, positive for nitrates, then that means that this woman is having something wrong. I need to do the culture. Okay, you are going to do the culture. The culture came out to be positive for whatever. Let's say I'm seeing virulent bacteria recently, honestly. For whatever bacteria, it came out to be positive, you are going to treat accordingly. If the patient is symptomatic, then you are going to give her broad spectrum antibiotic after taking the culture. So you are going to take the culture first, start broad spectrum antibiotic, which usually it's going to be nitrofurantoin, and then after the culture came out, either you are going to continue on nitrofurantoin or change it to another agent according to the sensitivity. Is it clear, guys? Okay. Okay, let's have one last question. Yeah, this one should be easy. Okay, let's take it easy. She's going to have a C-section. Okay, if this woman is having intact membranes, would you give her IAP or not? No, no need. The baby is protected, right? The wall of the castle is closed. So the baby is protected. Okay, now the woman is going to have a C-section. She is GPS positive. Are you going to give her IEP or not? Of course, of course. Even if she's going to have a C-section, yes, because the wall of the castle is open. The baby now is jeopardized. He's going to get the GPS. Even if he's not passing through the vaginal canal, he still can get it. Okay, now I know that I'm going to give her IAP. There is nothing about allergy here, so I'm going to give benzyl penicillin. Okay, the woman is 38 weeks. I don't think that I should think about corticosteroids at this age as a priority, but I'm going to keep it in my mind. Okay, there is no contractions. No contractions. Okay, and she already planned for cesarean section at 39 weeks because the membranes are ruptured. She need IAP because the membranes are ruptured. Exactly, Dr. Khan. Any ruptured membrane, guys, with positive GPS, you are going to give IAP. Now the question is, are we going to give benzyl penicillin plus CS after corticosteroids or benzyl penicillin plus category 3 cesarean section? And this could be EMQ. And if it's an EMQ, it would be very ugly. She is 38 weeks. Do you think I'm really eager to give corticosteroids? I don't think so. Exactly. And this is why the answer was whether it was category 2 or category 3, it's going to depend on the CTG, of course. But they didn't mention anything that the baby is having any problems. So this is elective cesarean section. Okay, and category 3 is when we are going to perform the CS in maximally 1 week. Yeah, exactly. Okay. No, it's not offered. It's not routine. It's not routine, Dr. Azim. Corticosteroids for planned CS. Okay, let me open up because this one is really important. I'm going to open the infograph of the college.